Hi, good evening, everyone, and thank you for joining us for tonight's Woo You event with Dr. Cecilia Ketting. Her presentation is titled The Nuts and Bolts of a Dry Eye Clinic, Building a Dry Eye Clinic. So I'll be your host tonight. My name is Dr. Ariel Sorenzi. So I'd like to introduce our speaker tonight. A lot of you may have already seen her a few times on Woo You. We just couldn't get enough of her, so we just keep on asking for her to come back. So Dr. Ketting practices in Denver, Colorado, and her primary focus is in anterior segment and ocular surface disease, neurooptometry, and perioperative care. Dr. Ketting is a fellow in the American Academy of Optometry, diplomat of the American Board of Optometry, active member of the AOA, and has served as both local and state officers in AOA. She was named Young Optometrist of the Year in 2019 by the state of Virginia and received the Vanguard of the Year award. Dr. Ketting lectures locally, nationally, and internationally at conferences and has written for multiple publications. So we're so excited to hear from you tonight. These are our financial disclosures, all of which have been mitigated. So I'll have you take it away from here.
Perfect. Thank you for such a warm welcome. And thank you, Woo You, for having me back. Always such a great audience. And so I'm really excited to talk to you tonight about some of the things that I find are the nuts and bolts of a dry eye clinic and how do we really build and get started. And I like to break it down because I've had to do this a couple times myself. I came from this large conglomerate of an amazing, well-oiled machine where I was practicing for a better part of a decade that had a fantastic dry eye clinic. And then I left and came to Colorado to really help this much smaller clinic build a dry eye clinic. So I've really gotten a lot of, kind of gotten my hands dirty and understood a lot more about what's important, what do I want to bring? And so that's what we're going to talk about is some of the different options that we have. Where do you start? Can you start with nothing? What's good to kind of maybe start to bring in and why is it important and why does it help? So first off, you've got to remember, TFOS dues, revised edition and definition of dry eye is that it's multifactorial disease of the ocular surface characterized by a loss of the homeostasis of the tear film coming into ocular symptoms because of that. We have hyperosmolarity and instability of the tear film. So at the base of it, we remember we've got loss of homeostasis and inflammation. Those are really the two kind of key things that I always take away from it. And there are, of course, different classifications of dry eye. And when we're talking today, we're going to talk a little bit about each one of these, but we're always keeping these nuggets in the back of our brain as to what do we see, what type of level is this patient at, and maybe what do we need to be doing for treatment. So I jokingly say this, who has dry eye? Everyone, right? Because until proven otherwise, I'm going to assume that anybody who's in my chair has some level of dry eye. Because that's true, right? Depending on the day, depending on the year, depending on the season, some people are going to have flares. Some people are going to be more chronic. But just because this patient didn't have dry eye 2 years ago, by the time you see him now, it doesn't mean something hasn't changed and they don't actually have some level of dryness. Because the US prevalence is estimated at over 16 million patients having been diagnosed, while 33 million patients actually suffer. That's a huge disconnect, right? That's 16 million and 33 million. We're looking at another 16-ish million people who haven't been diagnosed. That's 50%. So we really need to be talking to our patients and remembering that even though they aren't saying their eyes are dry, there's other things that they might complain of or not realize is actually dryness and that they're suffering from. And the other thing is when we talk about dry eye, we have to start talking with our patients and remembering, that again, multifactorial, which means that there can be lots of entry points into this as to what are causing it. So inflammation from systemic diseases like rheumatoid, lupus, Sjogren's. Think about other things. What about patients who have other inflammatory diseases in their body, like gout? Crohn's, talk about patients who have IBS, other things that can cause inflammation to rise in the body. Other things where we've got hormonal changes with menopause, medications being taken, such as hormonal birth control, meibomian gland dysfunction. We've got other issues when we talk about environment, medications, contact lenses, whole host of things. We know this, right? But we got to remember to ask questions. And these are some of my favorite ones is, have you ever noticed that patient who has one eye that's dry, but one eye that's not? Do you ever sit there and think, okay, well, wait, where do you sit in your car? Are you always a passenger or are you always a driver and you always have a vent? That's me. I always have a vent on me because for some reason I'm always breathing. Or do you sit in your home in a chair that's right by a vent? Do you favor one side of your face when you're sleeping and maybe we're getting a gap and that's leading to dry eye or dryness on the front surface? So the other thing too is asking your patients, we might be good about asking about computers at this point. And so we say, oh, do you read a lot? Are you on your computer a lot? The next question should be, are you on your phone a lot, right? Because some patients will say, oh, I'm not really a reader, but they're on their phone for 3 hours a day, sitting here like this. And we blink 50% less anytime we're doing things where we concentrate. So that's going to lead to more issues with meibomian glands as well as just overall exposure. Again, talking about that whole body influence, we got to ask questions. We need to look at what medications they're on, what other things are they being diagnosed with, and investigated, right? They may not, some patients have a full diagnosis, but ask them, are you working with your doctor on any diagnosis or are they suspecting anything else that might be going on? Medications, even ocular medications. Think about glaucoma medications where we're keeping our patient from going blind, but they have typically BAK, which can really beat up that cornea. So thinking about other preservatives that we may be exposing that front surface to. Systemic medications are antidepressants and anxiety medications, sleeping pills. A lot of times patients, like my husband, will take Benadryl or Benadryl-based medications or, the active ingredient that's in there, and that can cause dryness. Pain relievers. Think about other things like Parkinson medication, chemo medication, acne medication that they may not be on currently, but may have taken when they were in their teen years. As well as right now, we've got allergy season, right? Everybody's taking everything. Are you taking your antihistamine pill? Is it a D? Does it have a decongestant? The decongestant is going to dry them out more than if they're taking a non-decongestant. So here's where we're going to start. Let's talk about, those are the things we're going to ask, right? And those are so important. This is your start to opening and really running a dry eye clinic, is you've got to start thinking about it, right? Next thing is using your texts to start to give us clues. So before they enter the room, the texts, videos and materials in your waiting room, you can send the patient's texts. You can actually send them dry eye questionnaires like the SPEED or the OSDI before they come in for their appointment so that you're gathering this information. I really like questionnaires. And again, so I had to start thinking about this when I went to the new practice. And what did I want to do? Well, I did both because I wanted to try them both, and why not? And 6 months in, I said, I don't like both. I'm not getting really a lot of information from the OSDI that I felt that I was using, and I felt more that I was getting from the SPEED. So I added a few questions that I liked from one into the other, and I created my own. And so that's really important because it gives me a measurement too that I can then go back to the patient and say, here, I'm seeing that you're improving based on your symptoms based on what you're putting down as your answers or how well you're doing. It also is great because I had every patient do this. It's free to me. I just print it off the internet. These are available on the internet. And it has the patient start thinking about it, right? Now I've put a questionnaire in front of them. They go, well, have I just been ignoring it because it's always like that? And I just kind of assumed it was always going to be like that. That's not normal. You're asking about it, so I assume it's not normal, right? So you're opening the doors of conversation. And then I think the other thing we have to think of, and we're going to kind of get into how to break these down, but remember in the definition of dry eye, they break it down into two different types, evaporative versus aqueous. Well, we know that they are definitely not mutually exclusive. I would, if you look at the statistics, it says about 40% is overlap where you have both. And I agree that that's probably 40 to 60% of my patients have both a combination of aqueous and evaporative dry eye. So we really have more patients who have that overlap versus a true aqueous deficient only or an evaporative only dry eye patient. So don't be shy to say, hey, look, we need to do lots of different things to attack both things, or even starting with the treatment in one area and say, I'm going to see you back. We're going to see how you do, and we're going to pivot. We're going to do what we need to do to change from here based on how you react and how you respond to that first treatment. My patients, I have that conversation a lot because I don't want them to think that this is a one and done. This is medicine. It's going to change. I'm going to change how I'm treating based on how you respond. So how do we determine the underlying cause, aqueous, evaporative, right? Or both, right? Diagnostic testing. What do we all have? Slit lamp. And that is where you're going to get so much information. Even if you don't have any of these bells and whistles, start here. Just start really paying attention to what we're doing and really doing a very thorough slit lamp exam. You're going to get so much information. Start with the lids. I don't think I paid as much attention to the lids as I have over the last probably 5-7 years of practicing as I did during the first 5-ish years of practicing. I really have started to pay a lot more attention to it because I realized I was missing so much and about half the story. Make sure that you're looking at the lid itself, right? Start with when you walk in the room. You look at the patient, they're sitting, we know to look, oh, are you slightly tilted? Things like that, other random quirky things when we talk about neuro, but we need to be looking at them as we talk to them. How often are you blinking? Do you have a decreased blink rate? Are you complete blink? Are you only partial? What other kind of cues are we getting from these patients? And then once they're in the slit lamp, then we need to start thinking about look, lift, push, pull. So we're looking at them. Don't forget I like to have the patient look down and then lift on the, can I do it on myself? There we go. Pull up, and I'm looking at the laxity and how well we're getting snap back, just like we do down here, right? We look at snap back there. That's going to tell me things about possible undiagnosed sleep apnea, poor lid closure because the eyelids themselves don't have, the muscle tension's not quite there. So other things that I need to possibly be thinking about in these patients. And then we need to look at the gland's appearance in looking for any pitting of the glands themselves, looking for any capping, and then looking at any lid structure abnormality. I also like to, when they're in the slit lamp, actually have them close their eyes lightly like they're sleeping so that I can see, are we getting a complete closure? And then also, like I said, looking for abnormalities. Do we have like an S shape? Do they have some scarring from something where we aren't getting, a complete full closure there, that we have maybe a little gap or something? The other thing that we need to do is then we need to push on those glands, okay? We have to push on them because we need to know what is coming out and how well it's coming out. I don't care what you use. You're more than welcome to use your clean finger. You can use a cotton tip applicator, which is typically where I go. Gland expressor, which actually is kind of cool because it gives a consistent pressure across the board. So it's always doing a consistent pressure. So you know that it's a little bit more control. The problem is though, what happens when you push on it? You're getting a consistent pressure, but no oil comes out. You're still not getting the idea of what it's going to look like. So even then you may still need to pull a Q-tip out or something to push to really get the oil out so you can see the consistency. And then you can also use forceps as well if you prefer these little gland expressors that are there. Again, don't care what it is, like Nike, just do it. Meibomian gland compression. So we're looking at the expressibility, things that we're actually going to note in our exam findings, right? So we're going to note how easily was it expressed. I usually put good expression, poor expression, difficult expression. So I'm grading how easy was it for me to get that oil out. The next thing, I'm actually going to grade the meibum quality. There is a lovely scale here on the slide for you if you prefer to use a grading scale. Grade 1 is olive oil or clear. 2 is we're starting to get cloudy and turbid. 3 is cloudy, but we've got more debris in there. And 4 is going to be more that inspissated toothpaste caseous. For me, I typically tend to actually just put what it looks like. I put the descriptors. And that's just because, you know, not everybody knows the grades, and or for me, it's a little easier. So there's no right or wrong way to do it. You can do whatever makes you happy. But we do want to grade it. That's the big thing, is putting some kind of descriptor or indication of what we're seeing and the quality of that expression. And I like this because I use this as a talking point with my patients too, right? So when we talk about what I'm doing, I say, hey, did you feel that when I was pushing on those glands? So the oil that comes out of those glands is really important. It has lots of jobs, one of which is being part of your tear film and keeping it from evaporating too quickly. And it also carries a lot of nutrients and growth factors that get into that tear film that help our eye function, or the front surface of our eye function. And you felt how hard I was pushing? Well, that oil should come out when you blink. Do you blink as hard as I was pushing? No, I don't. That's right. And so that oil is not coming out properly like it should to get into that tear film, and that's part of the problem. So it kind of builds that beginning a discussion with the patient of what we're doing and getting them to understand why it's abnormal. Other things we're looking for is blepharitis and DEMODEX. So we will, notate, do you see any saponification? Lid margin debris, what grade? I usually grade it 1 to 4. You can do mild, moderate, severe. Lid margin biofilm. So remember, that's kind of that thin crust that's right over the glands. And that's not good either because it makes it difficult for that oil to come out. So we do want to note if we're seeing that. Collarettes, because remember, those are pathognomonic for DEMODEX. Telangiectasia, how much redness? I usually put, a T. I put the number in a T based on what grade I'm going. And then lid margin thickening. So these are things we want to notate within our grading of those lids. It's a lot of stuff for the lids, isn't it? But it's important, especially when we're looking at dry eye disease and talking about ocular surface disease and meibomian gland dysfunction. So we got to talk about DEMODEX, guys. I know nobody really wants to. Some of you just ate, some of you are going to eat dinner soon, but promise I'll keep it brief. These are some of the things these are some of the manifestations that we might find with DEMODEX. So when people say, is DEMODEX really a problem? Yeah, unfortunately it is. It's part of our natural flora fauna and it's supposed to be there, right? But we need to keep it under control because it can start to lead to these issues. We can get increase in lid margin inflammation, meibomian gland dysfunction. We can get disorders of the eyelashes. So we get trichiasis, we can get misalignment, we can get matarosis, we can get inflammation. These little guys can lead to more problems with marginal corneal ulcers, as well as other corneal problems there. And why? What are they doing? Well, they've got threefold things that they're doing. Mechanically blocking those oil glands because they're getting in there, they're dying, they're excreting stuff. So they're blocking it, right? There's mechanical blockage there. Bacterial, well, what I just said, they're dying in there. They're leaving their, exoskeletons that are covered in bacteria. They're excreting bacteria, all this stuff that's pretty gross and not good. What does that lead to in the future? It also can lead to a hypersensitivity response by our body. And then chemical as well. They've also been associated with a altered meibomian composition. So all of this stuff, not good, right? That's why when they get overgrown, not great. We got to keep them under control. Luckily, we will hopefully in the next year-ish have another option. How do we identify it? Because that's what we're talking about, right? Slit lamp exam. Have your patients look down. I tell you, I started doing this 4 years ago, I think at this point, maybe 3 years ago. And I really wish I could take it back because unfortunately, it really does help you identify more. I also like to take photos of this for my patients so I can show them. If somebody showed me a photo of my eye looking like that and that I had all that gunk in there, no, I'd tell you, yeah, whatever, let's clean it. That's not good. We don't want that. So little video. That patient looking straight ahead, right? Doesn't look too bad, pretty clean. looks all right. We probably say, no, they look fine, right? Have that patient look down. Now, what are we seeing? Yeah, we're starting to see a little bit more at that lash line. Yeah, so important. Next thing, vital dye, right? We all got this in our office. Corneal staining, it's important. Don't think that, you know, oh, I can see it without stain. You're right, you can. And if you can see it without stain, guess what? That's not good. That's really bad. That's pretty far along as far as dryness, right? But you need to put the stain on there because we need to catch those people who you can't see to the naked eye. So sodium fluorescein, looking at, again, when you're looking at these things, look at the pattern, look at the location, and look at the severity. All those things are going to give you clues as to what's causing the problem in these patients and give us a better idea how to tailor our dry eye treatment for these patients. Tear breakup time, we need to note that. Also, get a Ratten filter. It actually is really helpful to catch those subclinical levels of dry eye and to kind of really give you a better tear breakup time in these patients. It's inexpensive. I got mine off Amazon. I keep it in my pocket, pull it out when I need it. Rose Bengal, we're really going to use that, remember, to look for patients who have HSV. So if we see corneal irregular staining, like in this patient on the photo, that is the patient we want to throw maybe some Rose Bengal on just to make sure that it's not somebody who has any kind of HSV going on at the same time. Okay, 3 very different photos, right? We look at the one on the far left. That person has probably 3+ coalesced inferior SBK. It's pretty dense, right? So I'm concerned maybe for incomplete lid closure, sleeping with an eyelid open, especially since it's concentrated down in that inferior portion. Second one, look at the far right. We've got more of a 2 to 3+ diffuse SBK. I'm concerned maybe about metamacosa, some allergy to BAK. Maybe this person's been putting something in their eye that they're allergic to. That's pretty diffuse though, right? So I'm thinking other things might be the cause here, or just even maybe a decreased tear breakup. And then we look at the one in the center and look at that pattern. It's a little different. It's concentrated, more superior, we'll call it temporal in this patient. Why is it in this one quadrant? And look at it. It almost has kind of this little whirl pattern to it. And if you look at the little individual areas of staining, they almost look more elongated and less punctate. And that's because this patient has limbal stem cell deficiency. They have limbal stem cell problems. And patients can have limbal stem cell issues with dryness because inflammation, it stuns those limbal stem cells. And so patients with severe dryness and or other things that can cause dryness often have this going on too. This is that next step. We need to be pretty aggressive in this type of patient. Don't forget to look at your lids and conjunctival staining. You can do this with lissamine green, and it tends to stain on the conjunctiva earlier. This might be a patient where I tend to pull lissamine out in a patient who doesn't have any corneal staining with fluorescein, but has complaints. This is a patient who may have, again, subclinical dry eye, and so we want to look at the conjunctiva for any staining there that may also be aiding to or causing some of that pain or discomfort for the patient. Okay, we're into the age where we need to be doing this more. Corneal sensitivity with anesthesiometry. You can do this qualitatively with a cotton tip or with a piece of dental floss. Don't use mint, or you can use a Cochet Bonnet. And the Cochet Bonnet actually gives us a quantitative measurement, but most of us don't have this. This is something that I had in my office because we use it for as far as for research. You can have one. It's great because then you can actually measure how long that little filament is, and that gives you a way to measure each time that they're there. Otherwise, go my fancy route of cotton tip applicator. You're going to tease out a little bit of it, and then I like to test multiple quadrants, the central, and then in 4 quadrants. And that's because you can have one area that's got corneal desensitization or decreased sensitization versus others. And especially if you have a patient who has maybe limbal stem cell, you'll look at that patient where they've got it, and it's only one quadrant, test that quadrant versus the other. It may be different. You may also have some neurotrophic keratitis. Why am I talking about this? Well, early NK looks exactly like dry eye. We need to be testing for this because there's a lot more patients who have NK than we realize, whether it's severe stage 2 or 3 versus stage 1. Schirmer's, not my thing. I don't do it very often. It's still a valid test. A lot of people really like it. Same thing with the phenol red thread test. You're more than welcome to use it. These are also easy things to put in your clinic. That, you know, if you're getting started, this is something you can order a pack of these and you can use it. It still does give you valid test information. Okay, so those are the things that we all can really pretty easily do in our office, right? Because we've got almost every single thing I've already talked about in the office, barring a few small things that you can probably pick up and bring in. So those are the easy ways to just start. We're going to talk about some of the other point of care testing that I think is really important and which ones are, you know, easy to implement into your office. So first off, we're going to talk about tear osmolarity. Remember, the tear's osmolarity changes because of fluctuations in water content. So as we have an increased evaporation rate or reduction in the tear secretion, we have an increase in that osmolarity. So we get hyperosmolarity. And that's a bad thing because it actually triggers a cascade of different things within the eye. So it actually triggers epithelial cell death. It leads to an increased inflammatory cytokine production, more cell death, goblet cell loss. So things that we don't like, right? When we're looking at these things, or at tear osmolarity, we're specifically trying to get the most accepted number is below 308 as the threshold of what we want. Anything that's over 316 is typically an indicator for mild to moderate severe dry eye. Variability between the measurements themselves or between eyes indicates that we may have some more severe dry eye. So we've got the couple options. We've got the old style tear lab that's here that we can see. The newer one, Scout Pro, has come out. Why do we like this? Well, okay. Can you just assume that anybody who has dry eye also probably has some hyperosmolarity? You can, absolutely. But what I liked about it is that it gives you something that you can say, especially as you're trying to feel more comfortable in treating dry eye and who needs what. This is a really good way for you to say, yes, the numbers don't make sense. We've got an issue. It also is really good for your patients. It's a really good discussion point. I used to have patients, when I had this in office, I would have patients say, hey, what are my numbers this time, doc? And while the reimbursement is not seriously high, so this is not necessarily a revenue stream for you, it does help in building your credibility as really having a dry eye center of excellence and having more data points to share with your patients. MMP9, I think of this very similarly to tear osmolarity. When we're talking about looking at this as an inflammatory marker, you can also say, guess what? Yep, you got dry eye, you probably have inflammation. But this is also giving us another data point. It also helps us as practitioners build our confidence in what we're doing. And that a patient does have inflammation, it really makes us go, okay, yes, I assume that, but this is actually indicating it. It also helps us show patients. See this test? This test is showing us that you have inflammation. This is a problem. We don't want this. We need to bring it down. Now, there is the question of qualitative versus quantitative. Some newer testing is looking at MMP9s and actually lactoferrin as another marker as things that we can test in office to give more quantitative. But a really cool study came out from Brusick and Kading looking at the MMP9 levels and the signal strength. So many of us who've been using this for years would say, oh yeah, no, I know if it's like a faint line versus like a dark pink line, this patient's got really bad levels of MMP9s being expressed versus, you know, it's improving. Well, they showed that. And that's really cool. So that gives us backing to a little bit more of a quantitative. It's not true quantitative, but we can say, hey, fainter lines does in fact indicate lower amounts of MMP9s on the ocular surface for these patients. Again, this test, easy to get in office. It's not something you have to buy a unit for, which is kind of cool. So it's a good entry point for your dry eye clinic. Reimbursement, you're not going to, again, not a revenue stream. This is something that's going to cover the cost of the test itself. You may get a couple extra bucks on top of that, but that's going to pay for your tech. So it is still something though that's pretty easy to bring into office. So meibomian glands, we know they're super important, right? We already talked about looking at them, grading them, everything. Well, we were talking about grading more function. We also have got to look at structure, right? So enter meibography. Meibography, there are lots of different options that have kind of made their way into the into our offices more recently. We've got the good old, LipiScan, LipiScan, and LipiView. But there's MyBox, there's, oh goodness, I'm going to draw a blank on names, aren't I? I know that Optase is getting ready to release theirs. That's a slit lamp based one. There is a number of them. So a lot more, a lot of them are actually slit lamp based, so they are a little bit more footprint friendly, but it doesn't matter, right? Another way, look, if you're not ready to buy something to bring it in, you can still use a transilluminator. It's not as exact, and let me tell you, it's really hard to take a photo with using a transilluminator and trying to take a photo at the same time of their glands to then show them. But you can, right? If nothing else, you're at least able to look at it and appreciate it. And why is this important? We need to grade the amount of atrophy. So we're looking at three things: atrophy, inspisation, and just complete gland dropout. So this is how we grade it. You can use the percentage. I typically will say percentages, again, because I think that that's easier to translate to other people. But that's what we want. So we are looking at this patient right here. I'd say they're probably 80 to 90% atrophied. We've got maybe 10% complete gland dropouts, and severe truncation. So the truncation is when we've got the glands that are starting to shorten. And then when those glands are like there, but they're squiggly and fat, that's when they are they're more inspissated. So they're clogged. They're losing their structure and their function because they can't express. So that's not good either. So say we've got that patient in photo 2 there, their glands are still, there, but they're kind of overfilled and squiggly. That's not a good thing. We know that that's probably a person that I'm going to go press on their glands and it's not coming out particularly easy. So looking at both structure and function, super important. Study that I did with Liz Yu, we looked at preoperative cataract patients. It was a retrospective study. We looked at the patient's meibography as well as their slit lamp exam findings as far as quality. And what we found was that more patients showed levels of gland atrophy than those who had slit lamp exam findings that we would have classified them as having meibomian gland dysfunction. So we really do need both there. Other things that we may already have in office that are worth using and utilizing maybe in a little bit of a different way for dry eye, think about your auto refractor, right? Your staff's going to look at that. They're going to tell you it went all over the place. It had to zoom in and out. Think about your corneal reflections on an atlas or some kind of corneal topography. We're going to look for smudgy placido discs like we see here. We see that we've got irregular shaped placido discs, and that's going to tell us there's something going on the cornea. And then when you look at the cornea, you're either going to see dry eye, like you're going to see some staining maybe, or maybe the patient has ABMD. Either way, we've got something going on in the anterior surface. So don't hesitate to use what we've got in other ways. Okay, so let's talk a little bit about treatment here. Couple protocols that are really cool for those of us who like to have something for reference and kind of like a step-by-step guide. Both this TFOS DEWS 2 protocol and steps, as well as the CEDARS, help to kind of give you stepwise. I like the CEDARS because it really breaks it down into the different types of dry eye, and then steps as your first line, second line, and third line, and other procedures. So these are a couple of protocols that you can reference, especially as you're starting out, to really feel more, confident in what you're deciding to do with these patients. Eventually, over time, you end up seeing so many that you just know inherently, I see this, we're reaching for this. But when we talk about our plans, we have to look again, going back to aqueous deficient or evaporative dry eye. Are we looking at MGD and somebody who's also got Sjogren's? What are we looking at? Because then we have to figure out, are we dealing with just inflammation? Or are we dealing with inflammation and obstruction? Obstruction's hard. Obstruction is not something we're going to really be able to do too much at home, or with topical medications at this point. So that may be something that we have to think about different procedures. So we'll come back to that. Artificial tears, it's Band-Aid, right? It's not going to fix the problem, but there are better artificial tears than others, right? They're not all created equal. We talk about this with our patients. We say, don't get certain ones, do get other ones. Things that we need to think about, why we want to use certain ones. I like to talk about what's in them so that we can remember why certain ones are important and what makes them different. DEWS, suggest a specific brand. Try to give them a sample if possible. That's my philosophy. You don't have to adhere to it. But I like them to know what they're looking for, and or give them a photo so that they know what they're looking for, because when you go to that aisle, it's crazy. I go to preservative free, and I think everybody should. Yep, it's not 15 years ago. There's not 2 preservative free brands. There's so many different options out there at this point. We just have to remember to counsel our patients to use them appropriately. Don't touch the tips of the eye, especially with that concern recently with the drops being produced out of, I think it was Global Pharma manufacturing. We do have to be aware of that, right? But making sure they don't touch it to their eye, making sure that if they get a multi-dose preservative-free bottle, they're throwing it away at the appropriate time, because they are not use them until they're gone. They're use them for 30 days or 3 months typically. But preservatives can add so much additives to the eye, BAK, things like that, that are going to, we're going to be kicking ourselves in the foot. We're actually making it worse with these things. Other things that we want to add in, hyaluronic acid. We've got gels and ointments, lipid supplements. We do want to avoid the BAK, vasoconstrictors, the redness relief, the things we know we typically tell them to avoid. Remembering, why are we talking about hyaluronic acid? Well, and I just wrote an article about this because it's kind of cool. I didn't know, and you may not know this, there's 2 different weights of hyaluronic acid. There's high molecular weight and there's low molecular weight. And they both function differently by the amount of water that they retain and help hold on the front surface. So while hyaluronic acid is really important because it helps with stabilizing the tear film, it binds and retains water, different hyaluronic acids bind different amounts of water. So while that's not on anybody's actual manufacturing list of what's in it is a high versus a low, it's kind of interesting. Maybe someday we'll have a different way of looking at it. But the hyaluronic acid, because it's helping to stabilize that tear film, also aids in helping with epithelial cell proliferation, healing, and migration. TREHALOSE, this one is more recently been in Tea's Ivisia, and I like it. It's also in a few others, as well as something that's very similar to this. So I believe it's TheraTears also has this in there, but they didn't really talk about it. And I wish they had, because it's such a cool component to the artificial tears. And what it does is it's actually a bioprotectant and osmoprotectant in nature. So it's found in the Rose of Jericho, which is it's a desert plant. And so think about a desert plant, right? It's dry, it's awful, there's no rain, and all the plants look dead. But guess what? Water gets reintroduced to these plants, and no, guess what? It's been protected. So it actually protected those cells so that when water is reintroduced, the cells did not desiccate and die. They were just essentially in hibernation. And so it comes back to life. Same thing with the front surface of the eye. The idea is that it protects those epithelial cells from desiccating and completely dying. It just protects them so that when it comes back to a situation where they are in a normal osmolarity, they open back up and they're functional. Can't talk about dry eye without talking about steroids, right? Steroids are okay if we use them properly. We have to remember, what are the two things we're really concerned? Steroid response, which is approximately 15% of people. Usually the more common time that that's going to happen is after 3 to 4 weeks of steroid use. Most of the time, if I'm using a steroid for my patient who has dry eye, we're talking about a flare. So they're probably using it for 2 weeks or so. If I'm having them use it more than that or longer than that, I'm going to see them in between to check because I need to know if they are. The other thing is cataracts. Well, cataracts are a gift of life, right? So not being flippant, however, they are, right? And most of the time we aren't using the steroid chronically and long term. If I have a patient who is a 60-year-old, and I'm going to put them on steroids for, for using for dry eye, and it might be one of my more severe patients where we need to use it more long term, there's going to be a conversation about that. Dry eye flares, yep, we're understanding that more recently within the last number of years that no, patients who have stable dry eye do get flares. I have dry eye. I will absolutely say yes. Certain times of year are way worse. So using the steroids for that really helps to calm down that inflammation and let the body kind of get back under control. Topical and oral prescription medications that we can also use that are in our armamentarium, topical cyclosporin. We have multiple strengths here. And there are some differences between the strengths, one of which being Sequa, which has a higher percentage, has actually shown more recently in some of their studies that they actually are getting with their percentage a quicker response than we traditionally did with the lower percentage cyclosporin in like Restasis. They'll start to have improvement in signs and symptoms within 2 to 4 weeks versus the traditional where we tell our patients, oh, 3 months will be better. But options, right? So we got multiple strengths of cyclosporin. We've got topical lifitegrast. And then don't forget about doxycycline and azithromycin in our patients who have rosacea and blepharitis. I'm going to bring up the study in a moment about doxy versus azithromycin. Sjogren's. Oral pilocarpine can be used. I don't typically do that, but especially if they've got oral, a lot of mouth dryness, I may use that. We've got amniotic membranes, amniotic membrane drops, autologous serum drops, got a whole host of stuff, right? We got tons of stuff. And especially when we have patients who they may not be able to afford or their insurance doesn't cover some of those things, such as the prescription, the traditional prescription, we may want to think about the membrane drops, the membranes themselves, and autologous serum. And we're going to talk about that a little bit in a moment. So homework, yes, do it every day, patients, and you too, audience. We need to take care of our eyes, and we know this, but we're our own worst enemy. Why do we brush our teeth and floss and brush our teeth? Why do we brush our teeth and floss our teeth? Because our dentist told us to, because we don't want to lose them. Why should we do warm compresses, lid hygiene, and nutraceuticals? Because I like my eyes and I don't want them to be damaged and I don't want worse dry eye. So I argue those are the bare minimum. We should be doing that. Lid hygiene, when I say that, I'm talking about day-to-day cleaning, not just, hey, we know we've got specific special things that maybe we need to be doing for blepharitis and DEMODEX, but talking about at least doing like a lid scrub or doing hypochlorous acid as a spray after you clean. I personally do both. When we talk about DEMODEX, we're talking about more tea tree oil, okra extract. We can talk about, oh goodness, Manuka honey. That's the last one I was thinking of. So we've got some other options that are there. But this, again, we're talking about some of the basics. Warm compresses, remember that the studies show that we need approximately 106 degrees or 40 degrees Celsius. And that's because that's the melting point of unhealthy meibum. It is not our natural body temperature. That's why it's clogged. So unhealthy meibum, we need higher temperature. We need it for approximately 8 to 10 minutes. Warm, wet washcloth does not hold the heat that long, nor does it get that hot. So warm, wet washcloths, not a great idea. We want to get them using a really good heated mask. There are some options for those that are USB pluggables. There are microwavables. There are DEMODEX and EverTears, which are a little bit different. One of the DEMODEX is these little hand warmer type things that actually also have cleaning solution on them. And then EverTears, and I hope I did not get these backwards. EverTears is the one, I think I did. EverTears, I believe, is the mask that you put into, it's got a little activator that you pinch and it heats up, and then you can actually put it back in hot water and it reliquefies. And so it kind of eliminates the need for a microwave, which amazingly enough, my patients in Boulder, a lot of them don't have microwaves. It's a thing. I mean, I don't say I blame them, but presents an interesting challenge when I'm talking about doing warm compresses. So matters of makeup. Let's talk about makeup. So you may say, oh man, I don't want to get into that. Here's my argument. Let's do just a couple things, right? What I do is when I'm in the slit lamp and I'm talking with my patient who uses makeup, and I can obviously identify this because they've still got it on there, or they put it on that morning right before they came to see me. Great. So with makeup, what do you currently use to remove your makeup? Nothing. I just wash my face. Well, we want to make sure that we are using a dedicated makeup remover, because washing your face does not get it off. We need to use something with like a lid scrub or micellar water. So we want to make sure we're removing the makeup with a makeup remover at night. Don't use waterproof mascara. It is very difficult to get off, and it tends to be a breeding ground for bacteria. Replace your mascara every 3 months. Again, breeding ground for bacteria. And we want to make sure that we're not, putting that thing back in the tube that has now become a little petri dish. Other things going beyond those three, if you see a patient who's still waterlining or tightlining their makeup, and men, what that means is that they're putting our eyeliner right on top of those meibomian glands. It has become less of a trend in general anyway, but guess what? We put that right over there. What do you think is going to happen? That gland's going to get clogged. Clean brushes, avoiding BAK, alcohol, parabens, all these other things. So we can really get into this and into the weeds, but I would say those are the big ones. The last thing I would say is talking with your patients who do eyelash extensions or do any kind of just eyelash, fake eyelashes. I hate them. They love them. You're never going to get them out of them. At least tell them to clean them with like a hypochlorous acid spray. It doesn't tend to break the glue down on the ones that are individually put on there, but it will at least keep them a little bit cleaner. And then the ones where they remove them, make sure that they're cleaning them with a hypochlorous acid as well. Eyelash, brows, tinting, and perming. No, don't care. Don't do it. It's bad. It's the same stuff you put on your head. It's toxic. Step further, like I said, we talked about a little bit of these. Next step, you can actually start to suggest safe cosmetics and facial products. Great ones that I love. Eyes are the story. We love eyes. We've got 2020 Beauty. Zoria is another one, as is the other one that I've got on there. So if you want to, you can start to become more familiar with those things and carry some in your office or offer them elsewhere. Nutraceuticals. I know some people love them, some people hate them, but I think they're really important. Omega-3 fatty acids is something that's low in our diet. We don't get a lot, but our patients, even when they say that they're on them, you need to go a little step further and say, okay, let's talk about what you're taking, because we need it to be high in DHA EPA. Studies show that we need a ratio of 3 to 1 in those, and we need it to be the majority of the omega-3s that are coming out of whatever they're taking. Because if it's not, it means that they're getting other stuff that's in their omega-3 and their body may be turning it to cholesterol or passing it straight through. Patients might argue, well, I don't like the fishy taste. That means it's rancid. You got bad stuff. Get rid of it. Don't use it. Use a good brand. My two go-tos are Hydra Eye and PRN. Nordic is great. There's some benefits that I like to Hydra Eye and PRN. They are things that I can get a little bit of a revenue stream for my office with. PRN anhydrous I can also get to ship directly to the patient, so I don't necessarily have to carry it in office. Couple studies here, the DREAM study and the VITAL study. Both of these were looking at omega-3s and the use as far as within dry eye. There's a couple problems with the way that the studies were designed. You can look into the slide. We don't have a whole lot of time, so I'm going to keep moving. But essentially, DREAM study compared it to olive oil. Well, olive oil as the placebo just tells me olive oil can help too, which doesn't surprise me because of Mediterranean diet. Bigger question would be, let's do a study on just olive oil. Nasal spray, yeah, I still really like this. It's awesome. It's a different option for patients who don't like artificial tears, don't like drops in general. There's also some studies that the company is doing looking at NK and regeneration of the nerve function with it. So kind of curious as to see what comes out of that. They have been working really hard to make sure our patients can get this and it's covered with insurance. I use it myself. It is fantastic. And again, remembering this is not reflex tearing, this is basal cell tears that are being produced. The same nerve ending at the front surface of the cornea that causes basal tears when we blink and throughout the day, we have the same nerve ending in the nose, and that's what it's stimulating. And that's why we're getting basal tears, not reflex tears. I said we'd come back to this. We've got azithromycin and doxycycline. I go to azithromycin. Using a Z-Pak has been shown to be just as effective for patients with rosacea as has been a month's worth of doxycycline, which has less side effects. Your azithromycin, and you don't have to worry about birth control being less effective in patients with using doxycycline. So I tend to go to that. Both of them, 1 month or 1 week, you typically get about a 3 to 6 month effect out of it for these patients. Topical azithromycin, I heard through the grapevine it was coming back, but then the company that was going to make it, I have not heard anything from, so I'm not 100% sure, although I really liked it when it was out. Going back to amniotic membrane drops and the actual membranes themselves, they are covered. The membranes are covered with CPT codes looking at, look what's here: epithelial corneal dystrophy, recurrent corneal erosion, exposure keratoconjunctivitis, filamentary keratitis, punctate keratitis, all dry eye, neurotrophic. It's in the dry eye family. Remember, we're talking about earlier about the testing of the corneal innervation. Yep, we got some here too. So with using a dried amniotic, I used to avoid it. Put it in the well of the contact before you put it on the eye. That makes it much easier to get it attached to the eye. I'm going to skip this little guy here. Vitamin A ointment, I love it. I don't use any other ointment other than vitamin A because vitamin A helps to heal the cornea and promote differentiation of the corneal epithelial cells. So not only are you helping the patient's cornea heal while they're sleeping, you're protecting it in the patients who have some exposure keratitis. This is my personal regimen. I won't delve into this here, but a lot of the products that I talk about with my patients, I use too, because we should be, because who has dry eye? Everyone, including us. Yeah. So we got to take care of ourselves too. Couple great places when you're trying to build up your dry eye clinic that you can start to offer products without necessarily having to carry them in office. Dry Eye Rescue and My Eyes, or helpmyeyes.com. If you've got a smaller office, you may not have the footprint. If you do not own the office, you may not be able to make decisions as to what you're using. Both of these offer profits to you via, their office sales. Obviously, you can still do in-office sales and get it this way. I really like My Eyes. Full disclosure, am one of their consultants, but I also use it, and it's because I've had to move between offices. And so I want to make sure my patients know where to get stuff once they leave my office. Even if I'm still selling product in my office, I want them to be able to get to it. I like my eyes personally because I don't have to pay a fee to be a member and have my own platform, which is nice. Dry eye rescue, still also really awesome. I say look into both of them as far as for options. Scleral lenses, I don't fit them, but believe me, I send my patients out for them. They are really helpful in those dry eye patients. Okay, I know we're running out of time here, so don't forget, we probably aren't going to get too much into punctal occlusion IPL. They're great options for offering in office. Even more so, I think that's important to do IPL with expression, especially thermal expression. So don't forget about that and have to remove the obstruction. So these are great things to have in our office to help these patients. Couple of options here. Okay, I got to play the gross video. Can I play the gross video and we'll be done?
Oh, yes, for sure.
Oh, yeah, because it's so gratifying for the patient and for us. Oh, yeah. Look at all of that. That's not coming out with warm compresses, guys. Nope. We still got to do something to get that out because she's not going to function properly till we help them out. So at that, I'm going to say thank you. That was a whole lot of data and information, and I say applaud you guys for sticking with it, but hopefully you got some pearls. In the meantime, please do not hesitate to email me. You've got a copy of the slides if you need them. I'm always willing to answer questions if you have them.